Good morning and welcome to the second in our 11 webinar series of our 2021 Virtual County Finance School. Today's program will be Healthcare Megatrends and Their Effect on Your County Budget. My name is Mark Levine and I'm the Deputy Director of the New York State Association of Counties. I don't have to tell you, the county budget and finance officers, that healthcare costs continue to be a major driver in county spending plans. While making health insurance less complicated is a growing challenge for all of us, there are some ways to reduce costs. As I've said this before to many groups I've talked to in the last few years, NYSAC was charged 11 years ago by our board of directors to help find a way to lower non-mandated costs that counties are facing. That has been a very difficult challenge to find ways to lower those costs. This webinar is designed to help county finance leaders better understand where healthcare trends are heading, so that you can anticipate changes in the marketplace. Whether you are buying first dollar coverage or self-insurance for your employee healthcare, you will want to hear about stop-loss captives, changes in the broker community, and Medicare carve-outs. The presentation this morning will include practical guidance that counties can deploy to better control costs and evaluate your future liabilities. Jeanette Stanziano is our Director of Education and Training. I would like to turn to her now for any housekeeping for this morning's webinar. Jeanette.
Thanks, Mark. Just a couple of tips for everybody throughout this program. We will be recording it as we normally do and posting on the NYSAC website under the Education tab and then under Webinars or County Finance School. We'll be posting the recording and a PDF of the slide deck after 2 p.m. today. Also, if you look at your dashboard, you will see a tab for handouts. If you click the arrow down next to the word handouts, you will see that there is a document posted there for you to download entitled the 2021 County Finance School OSC, meaning Office of the State Comptroller, CPE form. Please download this and use this as your document that you will be submitting to OSC for your CPE credits. Please also note that you can use this form, just one form, for the entire program of webinars throughout the County Finance School. There's a checkbox and all the listings of all of the workshops on the back of this form, and you need only to download one and just check the boxes for the programs that you've participated in. Mark, I think that's about it. The floor is back to you.
Great. Thank you, Jeanette, and thank you for coordinating the annual County Finance School, this virtual County Finance School, with the Office of the State Comptroller and the County Finance Officers and Treasurers Association. We appreciate all that work. We have several special speakers this morning, and I'm very much looking forward to their presentation. It is my pleasure at this point to get to introduce the moderator who will take over from there. Winona Flynn, Noni Flynn, is the Treasurer and County Administrator for Yates County. Noni has been the Yates County Administrator for 2.5 years now, and prior to that, and even still, she is the Yates County Treasurer and Budget Officer. Noni has served as a past president of the County Treasurers and Budget Officers Association. In fact, she told me just now she was the president at our last in-person County Finance School. So thank you, Noni, for that. And we look forward to all coming together again in person. Until then, we're pleased to offer this session this morning. Noni currently serves as a member of the Municipal Healthcare Financing Collective, which will be one of the key topics of this morning's presentation. Noni is a graduate of the John Carroll University. Noni, thanks for being here and thanks for moderating this morning's session.
Thank you, Mark, and thank you, Jeanette. Good morning, everyone. Yates County has benefited directly from the New York State Partnership Program that is part of this session. The Municipal Healthcare Financing Collective enabled us to self-fund our medical benefits, saving over $500,000 last year, and also qualifying Yates County for a New York State Shared Services grant. We trust that you will consider joining us in these efforts to control your future healthcare costs. Let's find out what insights we can learn from this team of experts from Alera Group, including Sally Prather, the Executive Vice President. She'll be presenting on mega trends in healthcare. Julie Coopers, the Clinical Review Director, will be presenting on high-cost claimant strategies. Anil Kocher, the Chief Actuary, will be presenting on reserve policy strategies. And finally, Eric Lintella, who I met 4 years ago at a booth at finance school. I was probably looking for chocolate at the booths that they have. And I met Eric. He is the executive benefit consultant with NYSAC partnership programs. And because I met Eric at this booth, and I think I didn't get chocolate, but I think I got some wintergreen mints, Yates County did join into the Municipal Healthcare Financing Collective, and it has proven to be truly a great boon for our county. So we're going to get started with Sally, one of my neighbors.
Thanks so much, Noni, and it's great to be with you this morning. Noni's right, I'm right here in Yates County, so right down the street. We could be presenting together, but we're in separate locations. So it's great to be with you. I have the pleasure of talking about some of the mega trends we're seeing in the healthcare industry. And Noni, we're glad you stopped by for chocolate because I've also got Eric and a few of my colleagues here from Alera Group who are going to be able to drill down on some of those mega trends and hopefully help you see how you can apply these to your programs. So I don't know if I've had enough coffee this morning yet to talk about some of these major trends, but we're going to give it a go. So the three topics that I'd like to cover first really dive into what we're seeing in the industry. And they're not necessarily new topics, but what we have seen in the last several months of the pandemic is that they have been accelerated. And many of our clients and employers and associations like yours across the country are starting to take a closer look at how these trends might be impacting their programs. So let's go ahead and get started. The first one I'm going to talk about is going digital. Many of you may already be offering your employee benefit plans on a consumer-driven digital platform, but if not, you may want to take a peek at accelerating your tech solutions as a business, as an association, as an employer who offers healthcare. Ellen Kelsey, as you can see here in the slide, the president and CEO on the Business Group on Health, talks a little bit about what we expect to see in 2021 as virtual care options have accelerated and individuals are now not so concerned about getting their care online because we were forced to do it during the pandemic. If I could see your hands, I'm sure everybody would be able to raise their hand, indicating that they probably went to at least one virtual healthcare visit over the last 12 months. And what we expect to see in 2021 and beyond is that there will be a focus on evaluating the quality outcomes of that care and the effectiveness of the patient experience. And obviously, along with that, the cost of those virtual care options. And as businesses offering healthcare to employers, you're going to want to explore the telemedicine innovations. Now, the industry was forced to go virtual during the pandemic, and what we expect to see is that will continue post-pandemic as well. Continuing on the going digital theme is we are all more accepting of the digital experience.
And many experts in the industry do not see telemedicine going away or a de-acceleration of that after the pandemic. Quite frankly, those of us in the healthcare consulting space for the last 15 years have been promoting the advantages of telemedicine. And there's just been a stigma around that for several years. And so even for those health plans where we saw employers include telemedicine options, individuals just were not taking advantage or seeing the value. But we've definitely seen a seismic shift due to the pandemic. And we do expect that to continue. So even post-pandemic, when things get back to normal and people start going back to see their doctors and for visits in the hospital system, you're going to continue to see that acceleration of the tech theme and the digital theme. And lastly, on digital, on the next slide, what we've also seen from sort of the 20,000-foot mega trend view is that the disruption in the labor market is forcing employers as well as healthcare providers and consumers to think about that contingent workforce and the expansion of automation to really get to those individuals in a direct-to-consumer approach. So you can see the founder here of DoorDash, who's just commenting in California, they're looking ahead and across the country, ready to champion new benefit structures. What we think we're going to see, and we've started to see that already in our space, is more portability, benefit programs being more proportional to the needs of the demographic of each group, and obviously a flexible approach. For any of us who've been around long enough, think of the old cafeteria style plan options where you're giving employees the option to pick those things that they might need that fit their lifestyle, that fit their family. And so now take that on steroids, putting it in a digital platform, and think of the ease in getting to those consumers. So definitely, if you're not thinking about a digital trend in the way you deliver your healthcare programs, you're going to want to take a look at that. So let's move on to the second area, consumerization. This is also not a new topic because my colleagues know for years we've been talking to employers about consumers as more prudent and health-conscious buyers of healthcare, or what we label patient-centered care, which we see is on the rise. So we've been trying to get employees to pick high deductible health plans, to go into the wellness programs and pay more attention to their health for many, many years. But a couple of things are converging right now in the industry, which I think are going to bring consumerization to the forefront. This is a quote here from the president of healthcare provider business at NTT Data Services. And again, when you combine technology and the things that we're seeing in other industry sectors, when we bring that into the healthcare sector, I think we're going to see a significant acceleration. The second point about consumerization on the next slide is really all about transparency. And one of the reasons why we're seeing consumerization on the rise is because data is available to you as a consumer, whereas 5, 10 years ago, you didn't know what the cost of care was, and it was really difficult for you as a consumer to pay much attention, particularly based on the way your health plans were structured. Now, with the advent of high deductible health plans and more strategic plans available to employer groups and individuals, the need for data is critical, not only at your level where you're managing plans, but also at the consumer level. And so you can now look at the cost of care for a knee surgery across facilities. You can look at the cost of care for your maintenance drugs, for any of those types of things that you might be consuming on a regular basis. And you as a consumer can make choices about where you receive that care. And we will only see an acceleration of transparency as we move forward, particularly with the technology available. Lastly, on consumerization. I told you these words were too big for me this early in the morning. Need some more coffee. But what we've seen in the marketplace, if we step back and look at what's going on in the industry, we see a number of mergers that are pushing us further and further in this area of B2B to C consumerization. And so what does that mean for you as a business, you as a consumer? Many businesses are teaming up to accelerate the purchase of care as a consumer and the information that's available to you as a consumer. So Livongo, who's been around for a while in the health and wellness space, making digitization of your care available, how you get the data from your Fitbit into a system that tells you how active you are, combining that with Teladoc in the industry, where you'll be able to have your virtual visits online. We're also seeing GoodRx and One Medical come together. And then more recently on the scene is Clover and HIMSS. Clover is a Medicare Advantage platform, and HIMSS is a direct-to-consumer platform targeting millennials. So you can see just the space is starting to really focus on how do they get to the end user and the consumer who is receiving that care. So good to watch what's going on in the M&A space when it comes to healthcare. The last area I'd like to touch on is ecosystemization. And what do we mean by that? It's really the digital marketplace versus the suite of benefits. And one of the things that we see on the rise because of automation and digitization is bringing that healthcare data to systems that can put it to use, and linking your health information between systems so that not only your providers and hospitals have that data at their fingertips, but the payers on the insurance side and you as the consumer as well. And so we're seeing a lot of integration in this space, trying to get the data to the right place to support that decision making that needs to happen in the ecosystem of healthcare. And I think that one of the great examples of this we see our insurers continue to coordinate and connect with these type of systems so that they can pay claims quicker, so they can get the information on how to make decisions about their population and what type of benefit programs might impact their population more effectively. And so again, you're going to continue to see data being available and the healthcare space using that data to make it a much more not only horizontal and vertical integration across all of those subsets, the payers, providers, and the consumers. And so that's my 50,000 foot view, the three trends that we wanted to talk about: going digital, number one, consumerization, number two, and the last one being ecosystemization. Now, how do you put all of that to work for you? I'm going to hand it off to, I believe, Julie, our clinical director, who's going to talk more specifically about high cost claimant strategies. So Julie, I'll turn it over to you.
Great, thanks, Sally. And hi, everyone, I'm Julie Coopers, and I am a nurse practitioner and the clinical director at Alara Group. And I'm happy to be here today to discuss strategies surrounding high-cost claimants. Next, please. So in general, only 1% of members are considered high-cost claimants, but these claimants make up nearly 1/3 of employer healthcare spending. According to a large study by the American Health Policy Institute, high-cost claimants, which are generally defined as members with paid amounts over $50,000 in a plan year, cost about $122,000 annually and are 29 times the average member cost. There is a pressing need for employers to help manage the costs surrounding high-cost conditions. Next. A large stop-loss carrier, Sun Life, conducted an aggregate analysis of its top high-cost conditions. The analysis included data on more than 40,000 members with stop-loss claims over the past 4 years. And if you look to the far right column of the table, you can see the top 10 high-cost conditions from 2016 to 2019. And it's likely not surprising that the top 5 conditions include cancers, end-stage renal disease, congenital anomalies, and sepsis. And those top 4 conditions really haven't moved much from their current spots. The report also mentioned several other interesting insights, including that over that 4-year period from 2016 to 2019, 24% of employers had at least one member with over $1 million in claims. And since 2016, the number of members with claims over $3 million has doubled. Next. So there are several factors contributing to the rise in high-cost claimants. Some of those drivers include an aging population. We know that Americans aged 65 and older are a population of about 54 million people, and they are expected to double by 2060. A longer life expectancy significantly increases the likelihood of members experiencing conditions that are costly to treat. There's also been an increase in patients with chronic and complex conditions. And there has been a steady increase of new specialty drugs. Pharmaceutical and medical companies continue to conduct research to improve treatment for chronic illnesses. And while these therapies have the potential to drastically improve the lives of members with those chronic illnesses, their annual costs are generally very expensive, often exceeding $50,000 annually. In addition to more specialty drugs, if you could go back one more, sorry. Yep, back one more. Thank you so much. There was just one more point on this slide, just talking about in addition to the specialty drugs, there's been a rise in advanced treatment options that didn't exist in previous years. And these innovative treatments will continue to be developed as time goes on. One such treatment is a gene therapy medication called Zolgensma, which is used to treat spinal muscular atrophy in children less than 2 years old. And this novel treatment essentially replaces the missing or faulty gene with a new working copy of the gene, which is an incredible scientific advancement for genetic diseases. However, the cost of this one-time infusion is about $2 million. Now we can go to the next one. So what can we do about these high-cost claims? The foundation of managing these costs is ensuring that you have access to your claims data to determine which conditions are having the largest impact on your plan's expenses. It is also critical to understand what high-cost conditions may likely affect your group based on the demographics of your population to ensure that you have the right programs in place to support your members. Here at Alera, we use a data analytics platform called Springbook to analyze medical and pharmacy claim information. Using claims data, we assess the cost, quality, and efficiency of claims and benchmark this data against norms. This information helps us to understand details of cost and utilization drivers, in addition to forecasting potential future costs and risk. One of my primary roles as clinical director is to use this data platform to review all high-cost claimants and drill down into their claims data. So we investigate what each member's claims were for, ensure that that cost seems reasonable for that particular diagnosis or service, and facilitate discussions with the carriers as needed. In one particular case, we had a member with end-stage renal disease who was receiving dialysis 3 times per week in a rural area of New York. The carrier was paying $2,200 per dialysis treatment, which was significantly more than the treatment cost covered by Medicare. So we questioned the carrier's exceedingly high reimbursement rate and help them renegotiate terms with the dialysis provider for rates more aligned with a usual payment. The treatment cost was eventually reduced to $495, which resulted in a $250,000 savings to the employer. And this same level of detailed clinical review can be used to assist in stop loss and carrier negotiations, which also may result in substantial savings for employers. So just a quick example, one of our members had a diagnosis of breast cancer and the stop loss carrier projected her future costs to be about $300,000. But detailed reviews showed completion of a bilateral mastectomy and subsequent chemotherapy by year end. Her future breast cancer costs were limited to daily oral medication and monitoring. This information was discussed with the carrier's medical team, and the projection was reduced significantly. Now, after identifying high-cost claimants in the data, it is also imperative to hold carriers and claims administrators and PBMs accountable for aggressive medical management, including utilization review and disease or care management. Care managers should be engaging high-cost claimants and assisting them with coordination of care, health education, and medication management to prevent escalation. If current engagement with members is less than satisfactory, you may consider outsourcing care management services to a targeted vendor such as Accolade or Quantum. Additionally, you may consider benefit design incentives for members to engage in care management or for compliance with condition-specific pathways. Another important tactic to manage costs is to assess for any site of service opportunities. So you may have seen or heard of J-code drugs, which are those drugs that are not self-administered. Typically, these include infusion drugs and chemotherapy. These drugs are generally very expensive, and the site where they are infused, whether it be a doctor's office, hospital, or home, can cause tremendous variation in the cost of a claim. In an effort to reduce the cost of these drugs and their impact on a plan's medical spend, we assess for any potential site of service redirection opportunities. For example, we had a member with multiple sclerosis who was receiving a J-code drug called Ocrevus at a hospital outpatient department, costing about $90,000 per infusion. We worked with the carrier's care management team to assist this member with receiving the infusion in a home-based setting. And not only is this option safe and more convenient for the patient, but the cost is much lower, about $35,000 now. So that saved the plan over $100,000 annually. And while these J-code drugs are usually on the medical portion of a health plan, there are hundreds of very expensive specialty drugs on the pharmacy side of the plan as well. Specialty drugs are oral or injectable medications used to treat complex chronic conditions, and they have become the fastest growing segment of the total pharmacy market in the United States. The Centers for Medicaid and Medicare Services define specialty drugs as those with a monthly cost of $670. However, these drugs have an extremely wide price range with an average cost of about $5,000 per month. As more high-cost specialty medications come to the market, it is important that employers have a transparent pharmacy partner to help them manage their pharmacy spend by leveraging clinical and contracting expertise. Careful selection and aggressive management of your PBM is key, ensuring that adequate step therapy and prior authorization are taking place, tier placement, transparency, and contract terms for rebates and coupons, and any other programs that they may have for specialty drug management. Additionally, you may want to consider mandatory specialty pharmacy programs with associated care management or outsourcing specialty drugs to vendors who specialize in alternate funding for these drugs, like a payer matrix or Price MD. Another critical method to contain costs and optimize care is to work on predicting risks via data-driven analytics and predictive modeling. This can include identifying common conditions and procedures among high-cost claimants and working with the carrier to conduct targeted outreach with this member group, like targeted wellness programming or disease or care management opportunities. Additionally, using a risk scoring tool within a data analytic platform can also help identify those members who may be emerging risks. One strategy we have employed at Alera is the development of monthly reports which identify members who are likely to be emerging risks. So, for example, based on the dialysis case I mentioned a few moments ago, we established a monthly report that identifies any new members on dialysis or being set up for dialysis to quickly identify paid amounts for each dialysis procedure. On a similar note, we also built a report which flags anyone with a diagnosis code indicating that they are awaiting an organ transplant, as we know those claims are very expensive. In addition, we created reports which flag any new high-cost claimants each month and any members who have reached about 30% of their stop loss spec. And these reports allow us to intervene with the carrier or PBM or care management vendor as early as possible to ensure that care coordination and management is occurring. Lastly, there may be situations which require the implementation of targeted solutions or point solutions, which focus on specific conditions or problems. Next. Point solutions are specific services that are provided by vendors that fill gaps within traditional health plans. A point solution might address a specific condition like diabetes or end-stage renal disease, or a broader category like the ones already mentioned, specialty pharmacy or care management programs, for example. I have listed 12 point solution arenas in the slide, but there are hundreds of these specialty programs within these categories, all with a similar goal of reducing cost while improving health outcomes. A detailed review of your claims data with your benefit consultant can help you determine if your group may benefit from one or multiple of these solutions. So in closing, with an increase in chronic and complex medical conditions and a rise in specialty medications and treatments, it is critical to understand which conditions are having the largest impact on your plan's expenses, and to ensure that you have the right programs in place to improve the health of your population and reduce the costs of healthcare. And with that, I will turn it over to Anil Kocher to discuss reserving strategies.
I'm Anil Kocher, and I'm a chief actuary at a Lear Group, and I've been a public sector actuary working on reserve policies and making sure the books are sound for healthcare funds where the public sector is self-funded. And I've been doing this for so long, I can't remember when I started. I think I was born a public sector healthcare solvency actuary. So with that, let's move to the next slide. Okay, in respect to having a fund where you put your money as a trust or a healthcare fund in the public sector space, it says that these funds are set aside to cover the obligations, and once a year transpires, you go, we collected X amount of money and now we have additional funds. So this outlines in a couple of bullets what is your responsibility. It's the best way to spend the money that benefits the plan members. You want to be sure that when you look at what you have as the balance of your healthcare fund, is there enough allocated to deal with excess exposure? Could it be a catastrophic series of events, too many large claims, as my colleague spoke to, once their claimant is there, and such as, and then do you have money on board to assure that you can handle pandemics? So the idea is, do I have policies for my standard required reserves, my potential contingent excess risk, and if I have extra money, do I have a policy known as a premium stabilization or accounting policy to deal with the money and how I bring it back into the plan in terms of rating actions on a go-forward basis? So the purpose of me sharing this is, we talked about trends, we talked about ways to manage the claimant once they're in there, and this is more when I'm running my plan, how to deal with the money, and from an actuarial perspective. Next slide, please. The standard reserves, say you had $10 million, the standard reserves, if you had it in fund one that you're required statutorily in most areas, is to have an IBNR reserve. This is what is known as your terminal liability reserve. You collect money, you put it in the plan, and I'm sure everybody who's on this call is fairly familiar with this reserve, but I'll go through it. And you sit there and you terminated the plan. You say, okay, claims will come in the following period of time that are respective of the claims that were incurred in that period of time for which we were operative. So that's called an IBNR. So you have some money and it's sitting in a fund, and you say to yourself, how much of that should be in my IBNR reserve? And actuaries get to call that out most of the time. Or if you say, okay, my operating flow is a couple of months, my IBNR reserve is a couple of months of claims, and your auditor approves it, but from my chair, it's an actuarially derived number. Then the second thing you look at, if you're going to look at your funds, and I say, here's 10 million, let's say 2 million was the reserve. That seems like a lot. You had 10 million extra dollars in the healthcare fund. And then you have a contingency reserve. So what does that mean? Okay, you may have some stop loss, you may not have very much stop loss, but you may have to be able to cover if you have a premium equivalent or working rate, and you have what you have the people who are first responders working for the county or city doing all their fantastic work. You know, they have a certain monthly contribution that they've negotiated through labor or, you know, through management. And you say, okay, let's look at this historically. For several years, it ran very well, but in a couple of years, it didn't do so great. So you say, how do we justify how much we can put aside as an asset on our balance sheet to cover the potential for excess loss? Where you get somebody who does this kind of work and they build a model and they say, you know, we think you should put away a couple $1,000,000 based upon our analytics. Now, some of you may say, okay, I'm fairly familiar with this exercise. I have an aggregate cover. Is it the corridor of risk that's not covered by my reinsurance? Usually the contingency reserve based on actual practice is less. So it's good to have this. So once you have a signature IBNR, you have a contingency reserve, you're sitting there and now you've bucketed money. And what is the justification for doing this? Well, you have at your operating healthcare services accounting board or your council, you have policies that say, based on a policy that's been voted and approved, we will do an IBNR based on these sets of principles. We will do a contingency reserve. And then the third thing is, say, just to sort of give a framework, the 10 million, we put 2 million in IBNR, another 2 million in the contingency reserve. We have 6 million extra dollars in the healthcare fund. Have we created a policy through our operating board that says, what are we going to do with this money? Well, in the actuarial or the solvency actuarial, this is known as a premium stabilization reserve. And generally what you do is you say, okay, we have this amount of money and we want to create a policy that says, we're going to amortize this back into the rates over some period of time. And so you go in and you say, for year X, we're going to bring some of that money back, like 1/7 of it. So what happens is you have in front of all the people that work for your county, all the first the police, they know we're fully reserved on the IBNR, the contingency reserve, and the extra money benefits us. They'll bring it back into the rates. And so when you present the rating action at the renewal cycle time, and within the renewal cycle time frame, you sit there and you say, okay, we're bringing $1 million back in, so nobody's getting an increase in their contribution this year. What happens as a result of implementing these policies is people take ownership, especially with the rate stabilization policy, and say, if we don't overutilize the plan, we may never see an increase in our contribution over an extended period of time. We know we're fully funded. We know we have a contingency reserve. We're operating a gold standard reserving policies that, you know, any auditor that I've experienced over me approved. And if Joey comes out from a fight in a fire and his daughter has to be medevac because she twisted her ankle at soccer, we know we've got all our people covered and they can walk out of there going, the last thing I need to worry about is my healthcare fund because it's up to speed, so to speak. And full ownership, full reserving, full solvency makes an actuary, when he presents these numbers, almost cry when he goes in front of a friggin' board. He goes, oh my God, you guys are on point as far as I'm concerned. So with that, next slide, please. Okay, and this is a more detailed thing. Develop a reserve policy. It says develop the reserve policies, adjust the policies as needed, present the policies to council. And I kind of spoke to this in a general sense earlier, outlined the intent of the adoption. If the council needs further clarification, oh, it has a LIRA's name in there. We'll present the clarification, adjust the policies. And generally what all this is really saying is we create these policies. I know you're familiar with the reserving. We create a policy for the reserve, it gets approved, it gets adopted. Your council or your enterprise, you know, in terms of public sector space, says, You know, we have code, we have to have a, you know, certain code that's in there. It doesn't necessarily have to go to county or municipal or code, but you have a policy. So when an auditor comes in and reviews your numbers, you pull up the policy and say, this is exactly how we do it. And these policies, when you present the reserves to your council or operating healthcare fund board, they say, per the policy, the reserves are X, and they're all fully funded. It's in account Y, and it's, you know, earning interest at, you know, certain stipulated municipal rates, or if it gets really big and you have a lot of money, which it's amazing, some have a tremendous amount of money, they actually pull it out and invest it in different ways, and that's to your privy. So that's what the policy work is. In conjunction with the policy work, which I've had the privilege of implementing across the country for several counties, and we presently, to speak of, do that work now, and people are very happy they've created this structure. This is a very exciting thing to do, and it works very well, and people that have these policies are very happy. And with that, I'm going to move to the next slide, if there is one. Next slide, please. Oh, this is just an example. So when you pull this down, what this shows you is, okay, at the end of the day, I have these policies. What else is there to it? Well, this is an example. On the left side is an example of IBNR actuarially certified memorandum. Then we have an example of a contingency reserve memorandum that says, okay, they build this number, they write it up, they sign it off, it's certified. Therefore, it's removed from any discussions within the operating cycle, board meetings. We've removed this, it's independently justified. And third is, okay, for that extra money I briefly spoke to, here's an example of how we take that money, say we've got on the balance sheet in our CAFR, or whatever our name is, or nomenclature for how we book the money. We've taken the money and looked at it and said we want to keep a minimum of X amount of dollars in the stabilization reserve, and any excess dollars, here's the amount that we're going to bring to board as a line item in the rating for that year as a adjustment downward if you have extra money to the rates. And now I'm working with enterprise where they just arbitrarily rose the rates 4% a year, whether they needed to or not. Now they're actually holding the contribution flat for 3 to 5 years, meaning they're going to burn off the cash. And then you can also write into your policy on the stabilization at the discretion at an ad hoc meeting. If you need the money for something that is related to health care, you can put that in there. It is the privy of the board from a quorum vote that we're going to use the money for something like adding more dental, more healthcare, wellness benefits, anything we can. So I, as an actuary, love this kind of work. It makes me feel good when I get to present it. And hopefully, if any of you are in the space where you're considering looking at how to bucket the dollars for the benefit of all these wonderful people that work for your county or city, I think that this is something that we can discuss if you're interested, but I'm just putting it out there as something to consider, and I appreciate it. I'm not sure, is there a next slide? I don't think there is. Okay, with that, I'll pass it off to Eric, and he'll finish this up.
Thank you, Anil. Hi, I'm Eric Lintola. I'm a certified healthcare consultant and executive benefit consultant with Alara Group. And I've met a number of you as we've worked with the Municipal Healthcare Financing Collective over the last few years. As you heard from Mark Levine, the members of NISAC have been very aware of the rising costs of healthcare and have looked for solutions or at least components to help control those costs. What we have today, the Municipal Healthcare Financing Collective, is a intermunicipal agreement that for the purpose of reinsuring stop loss. So it is for the self-funded groups in what is known as a captive arrangement. So the member groups are working together to reduce costs and it comes through in the stop loss agreement. Each individual member has a stop loss contract that is rated on what's called a break-even basis. So over time, it's not supposed to make money or lose money. But what happens is, as the groups work together in this IMA, the law of large numbers works in your favor, where it's usually working on behalf of the insurance company. So as the pool grows, the individual counties are funding their stop loss premiums, and they're actually paying more than they're receiving in benefits normally. As the group, the opportunity is to receive back those unused premiums for that reinsurance in the form of a pro rata share based upon what they each paid into the plan. So what it's doing is it allows counties and other municipalities to leverage the fixed cost of stop loss and bring money back. And for some of you larger counties who have said, oh, I've got enough money set up in these reserving accounts that Anil was talking about, it would enable you to bring in stop loss for those shock claimants, the $1 million, $2 million, $3 million more claimants, and say, I'm not funding all the money in and not getting anything back. I can receive some of this premiums back by working together with the MHFC. So what are we doing here? We're looking to reduce costs per employee enrolled and strengthen your financial stability. So it looks to build up reserves, lower future trends, which is the rising cost of healthcare, and reallocate monies back towards other financial initiatives that you have. We recognize that healthcare has been gobbling up more of the pie, and this is a way of freeing up some of those dollars. And the example that Noni Flynn had in Yates County is just one of the situations that we're running into. It gives you more control of the spend of your healthcare dollars. And by working together, creating a larger pool, we have the opportunity to work with the case management to intercede and advocate on the clinical issues to drive down costs, to implement other programs, and not just be at the mercy of the work being done by your carrier or TPA. Next. Now, the MHFC went live in 2020, so we're in our second year. So what we've done is we've used this example of a similar captive program that we have been doing now since 2014 for private colleges in New York State. When we did the demographic analysis, they were incredibly similar to the municipal age and distribution of employees and their dependents. The benefits tended to be largely unionized, and we had a very rich plan design. So they're very similar groups. What it did is, starting with $2.4 million in that's the reserving contract, but with the plan has grown, excuse me, and then we've seen that the members have been able to beat their budget, which they set based upon historic trends and their internal needs for stability of their fund. They've been able to beat that for claims costs, including their IBNR, and to build their reserves by not having to pay the money out to the insurance carrier or pay it out in higher cost of claims. So this is how the law of large numbers works. If we did that for the MHFC, we've had first year data just closing out with that IBNR and then going into the next year's. That's why we want to encourage those of you who are self-funding or fully insured and considering self-funding to talk with us about how to participate, to build the fund, to take more control back to you and the other counties. Next slide. Next. The second NISAC partnership program, and this is a new initiative to say, okay, we have employee costs, there's pieces we can do to save money. What about our retirees? Most, but not all counties are covering some factor of retiree benefits. What this is specifically looking at is the healthcare costs, and we're saying you're bearing all the brunt or the majority of the cost of those benefits. In order to make any changes to save money, you must meet or beat the existing benefits, so you have to be equal to or better than. Otherwise, the labor disruption is a non-starter. You'd have to renegotiate a whole new contract. Even though the retirees aren't technically voting for the union is looking at this as one of their critical issues. So we've put together programs that have better than or equal to benefits across the board, no matter if you're if they're on your current self-funded plan, if you're in NISHIP, if you're in a local carrier's retiree benefit program. So we know we can do that. Then you have the whole struggle of my retirees don't all stay in county, they don't all stay in state. So we have to have access nationally, or you have to have multiple plans. So you have a local plan and a national plan, which gets even more expensive. So what we've done is we've built the model so that it's open to any Medicare provider anywhere in the country. So we've eliminated the access issue as a stop or a deal breaker on behalf of your union plan. And face it, if you're a financial decision maker for the county, you want to be able to retire and have access to quality benefits as well. So that's the second component. And then we're bringing in more work on our part to hold the hands of the retirees and your HR department. So we're willing to take over more of the responsibility for the communications with the retirees, because as we've looked at, so many of your county HR departments, personnel departments, are spending an inordinate time dealing with the retirees, especially come late summer when they start getting all their mail from the insurance companies about this is what's happening in Medicare for the next year. We're looking to be able to do that work, and we have a long-term track record of dealing with retirees and holding their hands. We went live this year in 2021. In 2021, we have we've looked at 7 municipal employers with a total of 3,002 Medicare retirees. So we're not counting the pre-65 retirees in this, even though we do have a solution for the pre-65 retirees. If, say, they're in NISHIP and you need to move them, we can discuss that. But looking just at those Medicare retirees on 7 public sector groups, we have driven and documented and offered $8.9 million in premium savings. So we're talking about a huge opportunity to bring money back to you as the plan sponsor. And those savings, the lowest savings we had on any employer, any of these public sector employers we've looked at was 9%. The range has been up to actually 51%. So we're looking at significant savings, typically in the 20 to 30% range off of what your hard spend is for these retirees. So we're looking at 2 components of driving down your cost in healthcare. One is the MHFC, the Municipal Healthcare Financing Collective, because it enables you to take control of the stop loss risk management component of your healthcare spend, and then carving out the retirees in a position that can lower costs and transfer the risk away from you to the insurance carrier so that we could work that way. Those are the partnership programs we have in place right now, and we are happy to run numbers for anyone in the group who's looking to say, what would this mean for my specific situation? All right, next slide.
That was great. I thank the Alera Group for bringing their expertise and their time to us this morning. I want to remind our attendees, and we have a few dozen county officials on the phone today or on this webinar. Please, if you have a question, submit it in your questions on the questions panel on your webinar dashboard, and we will take up those questions as we receive them. In the meantime, I do have some questions to Julie. One of the things that you're talking about as a way to and here's a key takeaway for me today as I was listening to this presentation, a great presentation again, is that we can reduce costs and improve our health outcomes at the same time. And that is something that, we're all busy and we're all trying to manage our budgets and manage our workforces. But it's critical that we think in these terms, and we can do this, but it takes a little bit of time. It takes a partnership with our health insurance broker or our health insurance carrier. So that's where I wanted to go to you, Julie. How do we ensure carrier accountability?
Oh, there we go. Sorry about that. I think I had myself muted. So that is a great question. One of the tactics that I have used is we have reports that are sent to us from carriers. They're called these early notification reports. So if it looks like they're going to have a high cost condition or they had a high claim, we get those reports sent to us. And when I receive those, I generally immediately contact the carrier or our representative at the carrier or care management vendor just to say, could I have a little bit more detail? What's happening with this claimant? Can you tell me if you think these costs will carry on into the future? And is there anything we can do at this point to not only help the member, but to try and reduce those costs going forward? Sometimes this has been helpful. So if we get a claim that someone is awaiting an organ transplant, for example, we may want to intervene quickly with care management to make sure that this member has everything they need, and also to make sure that wherever they are receiving care is within network and it is the best place that they could be going. So that's one of the tactics we use. I also, just by looking at the data every day, I always am looking for, are there any sort of gaps in care that I'm seeing for groups? Is there a high prevalence of specific diseases for groups? And if I see those things, I reach out to the carriers to figure out, what are we doing about this? Groups have had very high rates of ER usage, for example, and I'll reach out again and say, is this something that the care managers could reach out to those members that are utilizing the emergency department often and talk to them and see what's going on with them? So different strategies along those lines.
Okay, great. And when you say we, you're talking about we as in Alera. So you as the representative for the county or the municipality that you're serving. Is that correct?
That's right. Yep. So myself as the clinical director, and then our health analytics team.
So then, so my next question is, for counties who are on the line here today who may not be working with Alera, how do you have that conversation with the healthcare consultant or broker that you're working with? Because you want to have that sort of relationship, and that might be a tough discussion. So how would you recommend that the members that are on the webinar today, how should they deal with that?
Mm-hmm. Yes, that's a tough question. I think that you can have the conversation with your broker to figure out, what are they talking to the carrier or PBM, for example, and then what kind of information are they discussing, and just asking them, how are those conversations going so far? Is there any more communication that takes place beyond just the annual utilization reviews? And talking to them about the conversations they're having, or maybe discussing with them what are their ideas about conversations they could be having with these carriers in the future to help improve those outcomes and reduce costs.
Right. So oh, go ahead. I didn't mean to interrupt you.
No, sorry. This was Sally. I was just going to tack on to what Julie had mentioned, but I'll let you ask your question, Mark.
I was going to say, if the consultant is saying that that conversation is not going on, like how do you encourage them to hear? Can you have this discussion with the carrier, or should the county be calling the carrier and saying, can we find a way to work together to reduce these costs and improve outcomes?
Mm-hmm. I would think that the county should be able to have that discussion with the broker and have the conversations flow through the broker to the carrier. But it's also important to have those conversations be transparent so that all parties involved know exactly what's being talked about.
Yeah, Julie, that's a great recommendation. And Mark, I was just going to add that as the broker, we sit on your side of the table and represent you. So having done this for employers and counties like yours, we know the questions to ask and have the data to help us address those questions. I mean, Julie gave some really great examples of just evaluating the data on a monthly basis and making sure that those reports get a look over every month. And we know that your time is valuable and it's not always top of mind because you have other priorities than managing the health plan. And so the broker should be your advocate in making sure A, you have the data, and B, that we're helping you evaluate that and bring those questions to your carrier partners and vendors to really address those on a regular basis. And Julie mentioned earlier in her presentation the database that we use. We partner with a firm called Springbuck, and any of our self-funded clients, or the majority of them, we have that data go through that data warehouse. Not every broker uses one. So that's maybe the first question is, are you getting the data from the carrier to help us address these high cost claimants and these areas of opportunity to improve not only the outcomes, but the costs associated with it? So it's a great first question. Are we getting the data?
And thank you very much. And I would suggest to county members that are on the call today, your broker works for you, and you really need to have that conversation. The broker does not work for the carrier, they work for the county. And in order for you to really take the reins of your health plan, health insurance plan, having that conversation is critical, and making sure that they are helping you improve health outcomes and lower costs in any way possible. We are certainly here to help. And Alara is here to advise. If you have questions that they may be able to answer, this is a good opportunity to do that. I have a question in: our members greatly underutilized our 2020 healthcare plan. Should we expect an exponential increase in 2021 and 2022? If so, how much? That's a good question. I'm not sure it's answerable, but I throw it out there to the group. Our members greatly underused our health plan in 2020. Should we expect an exponential increase in 2021 and 22? If so, how much?
Well, this is Eric. I can see everybody else wants to listen to an answer and then respond back. The statistics are showing that so much of high cost care that could be deferred, so elective surgeries, were not performed for all those reasons we know in 2020. And even with lockdowns being lessened and the vaccine coming up, we have also had continued slowdown in those trends. That is just creating the backlog for future costs. We've also seen the move to more and more telemedicine or virtual office visits, which, as Sally was sharing, is not going away and is only being utilized greater. So the use going forward for this year and beyond is not clear. It is not going back to 2019 plus 8% annual trends. We are entering a new environment. I've seen some statistics, but I'm going to throw it out to my other presenters who may have seen better numbers than I did to take off from that that initial comment.
This is Neil, the actuary on the team, and the Society of Actuaries is analyzing this all the time. And I attend the public healthcare public sector work group, and this is forefront in what to expect. And back to Eric's comments, it's unclear. There's concern that it's just going to explode. But if you're self-funded and you funded your account based upon bringing money into the account from the county in some form or fashion, you may have actually built cash and you have excess dollars in the fund. And even though claims costs do get higher, which is anticipated, you may have the cash already to cover it. That's part of the reason to have stabilization reserves, is to make sure when things swing wildly based upon things beyond your control, you have the cash to fund it. But the long-term outlook is really in line with, if the adoption of telemedicine and all these other areas come to the forefront and pick up, things are going to be different than we expect. It's very hard, as was said, and I'm just doubling down, to take what happened and build upon that for the future. So Eric is exactly right from the actuary's view, that we don't know, but we're seeing this shift that Sally, one of my other colleagues, spoke to, that it's such that it might not be as bad as some people are saying it's going to be. So there's just a comment to say, we're looking at it all the time, and it remains to be seen, but we think it's going to be maybe in the middle of a worst case versus a middle of the road. So I'll let it move on to other commentators.
Great, thank you. Yeah, it definitely seems like we're at a bit of a crossroads here in terms of our healthcare costs and healthcare coverage. And telemedicine is certainly one of the key components of that. And I'm glad we were able to cover that today in this webinar. While we're still talking about the broker community, and we talked about transparency a little bit, Eric, you and I have had this conversation. Can you talk about a new law or a new policy that's taking place at the end of this year in terms of broker transparency?
You know, one of the things that happened under the COVID Relief Act, which was thousands of pages, was the inclusion of a transparency law effective December of this year, making it mandatory that your broker consultants provide their compensation in all areas to you as the plan sponsors. And while you might say, I know what I'm paying my broker, that's fine. But as I've met with a number of you, many municipalities do not know how brokers get paid. Not only are there commissions, dollar fees, fixed payment fees, but there's also compensation at times, or many times, back on a per prescription claim basis. So a piece coming back from the prescription benefit manager or the TPA for that. I've seen brokers, consultants being paid on network access components. So, and in the most egregious situation, I saw a compensation on 7 different aspects of a group benefit plan, a large employer benefit plan. So what's happening, and you have the right to ask, because as Mark shared, the broker consulting community works for you, even though they're often paid by the carriers for the knowledge of what is going on, where all the money is. And when you start seeing them come together, many times you say, well, I know that we're paying them, pick a number out of the air, $50,000. Well, $50,000 might be the baseline, and they're getting paid beyond that. So those rules start in December of this year. It's unclear. I mean, these rules have been talked about and presented in Congress for many years now, and have been not implemented. Strangely enough, the healthcare industry doesn't really want you to know how much people are being paid. But with the COVID Relief Act, it was pushed through. That means come December, but you might already have finished up your renewal by then. So put that on your to-do. Ask, how much are you getting paid? Where's the money coming from? Which one of these different components are you part of? Is the advice that you're giving me based upon what you're being compensated? All those are real issues, and I'm not casting dispersions on any broker. I've been a broker in the municipal space for more than 30 years, so I get it. But I'm seeing that you might not know who's getting paid what. And for the first time, you're going to have the regulations on your side in transparency to know going forward. So start asking.
Right, that's right. That takes place in December, but the process for picking your carrier or broker for counties can begin as early as now, as April, and go through August or September. So as you're going through the process and figuring out what your healthcare coverage will be for 2022, you can ask that question and start to uncover some of those things, making sure, again, that your broker is working for you and your employees. I want to take a little bit of a pivot here and talk about the Municipal Healthcare Financing Collective. As Eric mentioned, in 2017, Alera Group came to us, and we had been working on trying to find ways to lower costs on healthcare coverage for counties, and they came to us with this program that had already been introduced to some a collective of private colleges in New York State, and successfully. So we started this Municipal Healthcare Financing Collective for stop loss, for creating a stop loss captive. And Eric, we are now finished with our first year of the stop loss captive in New York for counties. And I wanted just to ask you, what was the performance of that captive? And what are we looking forward to for 2021, 2022, and going forward?
All right, the captive started for January 1st of 2020. It was an intermunicipal agreement between Columbia County, Ulster County, and Yates County. On the stop loss component, we were at a break even in the first year. So there was not going to be a return of premium, and we expect that once every 5 to 6 years. So that was where we started. However, each of the counties had wins by working together. Yates County, as Noni shared, were able to, as a small county, self-fund affordably and reduce their healthcare costs by over $500,000 and have that as part of shared services. Normally, I don't get to talk about wins like that in 1 year, but that's what happened for them. For Columbia County, they had one of these genetic high-cost claimants, and it was right at the conversion of the plan year, and their stop loss renewal was going to be hit with the more than $1 million claimant and the component of that would be booked forward, plus the lasering was going to expose them to even more costs. Working with Julie and her team, we were able to get the stop loss renewal down to less than market increase with a minor change in the lasering, which ended up representing several $100,000 of savings for the county. And at Ulster County, we were able to move their prescription contract from I will call it a collective buying, but it was a collective buying with hidden costs. So our trend, we took a trend that was going up by over 9% and had an absolute decrease of $1 million, $980,000. So all three members had huge wins, and the MHFC is structured in such a way that going forward, the partners, the member groups can use those tools as they see fit to manage their healthcare spend. So yeah, we We had a win in that we were able to have groups that had significant shock claims. I mean, a group of 3 isn't large numbers. We need to get this, so it's several thousands of employees in the program, which is why we're looking to grow. But even in that situation, it was a win for the members. Thanks for asking, Mark.
Yeah, no problem. Thanks. And that's kind of like the worst case scenario of this captive, right? Is to break even, but it was still a overall savings for the members of the collective. So that's a good answer, Eric. Thank you very much. And I'm going to shift one more question. I know we're at the 75-minute mark, but I want to ask the one more question, and that is this Medicare program that we're now working on. Why would a county want to consider this? And is there real savings for a county's budget with this new Medicare program?
Well, we're we're reviewing data from 2 counties as we speak. One that it's literally $2 million in annual savings with still the potential to move mid-year, to move in the 3rd quarter, which would, the pro rata savings would still be just under $1 million for the final 5 months of the year. So money is one reason. The second is that it meets or exceeds all contractual agreements in place. So it is a program that doesn't set you up to getting sued by, pick a union. It doesn't mean that people won't complain, because that's how it works. We understand that, but we're taking the time and effort to manage that process, to work with the retirees, with a team that has been working with retirees in the municipal space for over 20 years. So it's not like we don't know what they're going to ask and how they're going to ask it. So we're thinking that for most counties, you're going to be beginning to look at, what are my ideas for the next budget year, next healthcare year? What's going to do January 1? This is the time to gather the data, because we run it based upon the demographics of your retiree groups over 65. That doesn't change much every year. A few people might die off and a few people age in, and the baby boomers are aging in quite a bit. And one of those answers to the question on what is healthcare going to cost you going forward, the big spenders are your spouses over 65 who are on your active plan. So the sooner that you get some of those people into your retiree plan, if it's insured and it's not your full risk and Medicare is taking a big hunk of that, the better your overall plan performance for your active employees is going to be. So it's a twofold answer. There's the opportunity to save significant dollars, 20% or more is a real number, and the ability to meet or beat, no matter what part of the state you're in, who your carrier is, including NISHIP. So that's why we did this. We're looking at where the costs that we can make a difference today, which doesn't mean changing everything that you're doing.
And I thank you very much, Eric. And I thank all of our presenters and speakers this morning, Noni Flynn, Sally Prather, Julie Cuppers, and Anil Kocher from the Alera Group. We appreciate your time and expertise this morning, and we appreciate the time and attention of our members for attending the second of our 11 webinars that are part of the County Finance School this year. This will conclude our program this morning. Thank you and have a great day.
Bye now.